Welcome to the Hard Things About Healthcare, where we get into the business and operations of healthcare that clinicians face every day, the challenges they present to delivering care and running clinics, and how they overcome them. The Hard Things About Healthcare is brought to you by Honey Health, the connected care platform for modern healthcare teams. I'm Matt Faustman, type 1 diabetic, and co-founder and CEO of Honey Health.
I'm Ginger Vieira. I've lived with type 1 diabetes for 25 years. I'm a diabetes author, speaker, and content specialist. Today we're interviewing Dr. Nestoras Mathioudakis, who serves as an associate professor of medicine at Johns Hopkins School of Medicine, specializing in the medical applications of generative AI. As co-director of the Diabetes Prevention and Education Program and an experienced instructor in clinical informatics, Dr. Mathioudakis offers valuable perspectives on both the practical and ethical aspects of AI in healthcare. Thank you so much for being here, Dr. Mathioudakis.
Oh, it's a pleasure to be with you. Thank you for having me.
Okay, so I would love to just start with the big question. Why endocrinology? How did you end up here?
Yeah, so there's a few things I think that drew me into endocrine. Early on in med school, I really liked the sort of the logic of endocrinology and the feedback loops of the hormones. It just doesn't require a lot of memorization, and it's just very easy to think through diagnosis. We have a lot of effective treatments in endocrinology, but early on, even in my residency, I knew that diabetes was something that I found very appealing. It's a common condition. It is a treatable condition, and the impact is great. We have effective treatments that can prevent these complications in the long term. But it's not just the medical side of things. I really think that diabetes in particular is a mix of science and art. I like the pharmacology and the medication management, but I think an equally important part of it is the behavioral management and the lifestyle. And so just partnering with my patients and being a coach and helping them celebrate these small wins that improve their blood glucose control is really fulfilling to me. And the last piece I would say is the technology. I'm a gadget guy. I love tech in my own life, and the evolution of technology since I finished my training in 2012 in diabetes is just absolutely incredible. The accuracy of these CGMs, how easy they are to place, and the AI technology and these hybrid closed loop systems have just made it easier to live with diabetes. And it's exciting to be part of a field where the technology is moving forward so quickly that I'm learning as my patients learn, and we're seeing things make their day-to-day lives easier.
Well, speaking on behalf of many people with diabetes, I am very glad you ended up in this field. So thank you.
Thank you for saying that.
Well, we are very fortunate and grateful that you are here. And you've done so much work. I want to jump into health disparities. You have done a lot of work in looking specifically at the differences in ethnicities and racial groups and their access to diabetes technology, CGMs and pumps specifically.
Yeah.
Can you tell us a little bit about that research, and then we'll dig in a little deeper too?
Yeah, sure. So this is research that we published about a year and a half ago in Diabetes Care. We were interested in understanding whether patients in our practices with type 1 diabetes were receiving CGMs and insulin pumps, really effective evidence-based technologies, equitably. So we wanted to know, are providers having discussions with patients in the same way? If they're offering the technology, is it being accepted? Is it being prescribed? And then ultimately, is it being, used by the patient? And so we did this retrospective study in our clinics. We looked at close to 2,000 patients with type 1 diabetes, and we had a really eager medical student go through the medical record and actually sift through the progress notes of clinicians to figure out, did a discussion occur? Was a prescription placed? And did the patient start the technology? And unfortunately, at every step of the process, Black patients had a substantially lower odds of all of those things occurring. And that was even after accounting for sociodemographic factors, duration of diabetes, diabetes complications, A1C levels. So it really couldn't be fully explained by, traditional social determinants of health and clinical.
Mm-hmm.
That was
Right.
really, really eye-opening for us. So we were
Yeah.
like, what is happening here?
Yeah. I mean, it's very concerning, right? And so what do you think as you dig into that? What do you think is driving that? And then eventually what solutions are you trying to develop to change this?
Yeah. So, there are potentially multiple factors at play here. So, at the time of the study, some of the criteria for who's appropriate for these technologies, according to the practice guidelines, were really subjective, right? They said
Mhm.
things you need a highly motivated and engaged patient who, can safely use the technology. Well, that's a very subjective criterion. A clinician has to make that judgment. And often, what I think was happening is that clinicians were relying on the degree of glycemic control as an indicator of whether a patient could safely and effectively use the technology, right?
Yeah.
So, if you can't achieve good glycemic control with multiple daily injections, how are you going to achieve glycemic control with a pump? And since over the last couple of years, we've learned that thinking is flawed, right? The person who
Very
is
flawed.
in a position to benefit from the technology most is the person whose A1C is farther from goal.
Right.
So there was some subjectivity in criteria. There were also some insurance barriers, right? You had to be monitoring your glucose a certain number of times to actually be able to transition over to a CGM. And, for various reasons, some of our lower income patients or, patients that we had seen in our clinics were not checking their glucose regularly. So it was an insurance issue. And then finally, there is the potential for just an implicit racial bias that
Mm-hmm.
that exists. And, that's a hard thing to prove. It's a hard thing to kind of accept that could be a factor. Um, so, as a result of this, right, this was really eye-opening for us in our practices. We joined the Type 1 Diabetes Exchange QI Collaborative right after this. This, for those of you who may not know, is this national collaborative of clinics, adult and pediatric diabetes centers throughout the country, focused on improving the quality of care for people with type 1 diabetes. And so it's sharing of best practices. And we realized after joining this collaborative that part of the problem in this area is that we're not capturing data about device use consistently in the electronic medical record. So the
Yeah.
very first step of a quality improvement project is being able to define your problem. But if you can't capture that information consistently, you don't know, am I not offering this technology? Um, am I offering it, but I don't know that the patient is using it because I can't tell from the EMR, or am I really just not offering it? And we have since actually applied for and received funding from the JDRF, now Breakthrough T1D, and the Helmsley Charitable Trust to address this problem in a different observational study.
Okay. So
You,
to collect better data so that then you can start digging into
Well,
racial
in part,
bias in
but
healthcare.
to standardize the way we're capturing the information, and then to develop a best practice advisory and informatics alert to clinicians when there's a gap in use of either a CGM or an automated insulin delivery system. So first, we needed to get all the centers to be entering the information in the EMR in the same way, and then
Mhm. Mhm.
we're confident that know who's not using, then we can trigger an alert to the provider.
yeah.
Yeah.
One of the first things you called out was just the criteria
Yeah.
for when to prescribe. And first thing that comes to my mind are just some of these global things that might exist that got put in place maybe a while ago. So one of my questions I have is these criteria, were they put in place by the device companies themselves, the hospital system? And how long ago were those put in place? And because it sounds like you all have revisited that, which seems like a pretty big deal if everyone's been following those criteria.
Yeah, I think there were several places where these barriers existed. One was the practice guidelines themselves, right? They did to some extent really emphasize, um, that you have a patient who's really highly compliant with self-monitoring before you would consider transitioning. That if you look at the guidelines in the ADA from 2016 to the present, that's been toned down. I don't know why this was a Medicare requirement in at the time of the study in like 2016, 2017, that you had to document a certain frequency of glucose testing.
Yeah.
There has also been requirements on frequency of insulin use, which has been relaxed over
Mm.
time. So it used to be like, basal bolus insulin, 4 injections a day, and now it's
Yeah.
any
And the
insulin.
frequency of testing has lightened up too. I remember when I first tried to get insurance approval for a CGM, I had to send in a spreadsheet full of blood sugar levels, right? And now you don't have to do that. So I hope that could change
Thankfully,
some of
that doesn't exist anymore. That was
it.
really
Yeah.
tough to get past.
Do you think just in general, I mean, would you not agree with I'll call it my opinion, that anyone taking insulin should be offered a CGM at the very least?
100%.
Yeah, I mean, there's no risk at giving this,
Mm,
right? Like, what's the hesitancy?
I would argue that many people not on insulin could benefit from CGM.
That too, yes, of course.
Amazing tools, but certainly anybody who is on a medication with a very narrow therapeutic window where too much is hypoglycemia, a life-threatening condition,
Yeah.
too little is severe hyperglycemia, also, potentially at high risk, should be offered CGM.
What could be driving? I mean, I get how the biases play into the prescribing something as complex as an insulin pump. I get how that gets fueled by,
Yeah,
but oblivious bias. But a CGM is so simple. Why is the color of someone's skin preventing a doctor from prescribing a CGM?
I will say the one other thing I didn't mention earlier was patient fact. So it is quite possible that uh, maybe past encounter the patient was like, I don't want anything stuck to me. I don't the
Hmm.
Yeah.
concern, or for whatever reason I don't want to be alerted to that. That's going to be
Yeah.
distracting me. They declined it, and so the provider has that historical knowledge with the patient, and
Okay.
their visits just don't offer it. And so one of the things in this project that we're doing is with this informatics alert, if the patient declines, we're trying to capture the reasons that they decline, right? Is it, a concern about cost? Is it concern about the pain or the aesthetic aspect, or just the alert kind of
The
burden?
visible stigma, also, right? Some cultures are more sensitive to the stigma of
Yeah.
disease. Yeah.
So we just don't know the answer to that because we haven't been consistent in how we're collecting the information about offering the technology and what the patient's response is back. And we need to do that work to figure out, to tailor interventions around the problem, right? If the problem is in fact at the patient level, that's a different intervention.
Yeah. Okay.
It might be too early, but have there been any initiatives that you might have tried or started to put into place to try to chip away at this number once you started to understand what the data was? And was there anything where you found even some mild success, even though it might still be really early?
One thing we're really proud of is since we joined the collaborative, the T1D Exchange, we had to map our CGM data to the collaborative. So we had to create these discrete data elements in the EMR to say this person's using this device and map that to this national database. Our CGM rates are now 91%, and they're above
Wow.
the far above the collaborative average. And I think in part, literally just the step of saying this is how we're recording that the device is being used was itself a prompt. to clinicians, right? It's there on the form, and I'm like, oh, really? I can't believe I didn't talk to this patient about
Yeah.
a number. I will say that we, with relaxations in requirements and guideline changes, there's been tremendous progress in CGM prescribing. That gap is closing quickly, and that is a pattern that's been seen nationally. It's the AID use that is the next hurdle, and I think we're going to shift our focus there. So that's one thing, is the data collection. The other approach we've been using at Hopkins, we actually have an ongoing randomized controlled trial now testing whether a diabetes navigator, who is a lay person with a connection to diabetes, can help support patients to start using these technologies. Because the process can be really complicated if you have Medicare and you're going through a DME company. The paperwork process and the trail of getting it to the DME and in the hands of the patient, training, and things fall off at various steps. So we're testing now whether extra support through somebody like a community health worker background can think forward for these patients.
Interesting. Sounds like there's a lot of work left to be done, but you guys are digging in.
Yeah, we're working hard. And this is an area of focus, I think, at many centers, just based on what we're hearing.
And I mean, this is an overarching issue in healthcare across every health condition. This is not specific to diabetes.
Right.
All right. Why don't we switch gears a little bit and get into a conversation that I had said I was really interested to dive in with you about, which is AI and healthcare. And as I was saying earlier, really loved your talk at the Diabetes Tech meeting about this intersection with AI and some of the ways that you're seeing it play out in the short and the long term. And so we'd just love to hear you talk briefly, maybe some of the points from the talk, or just some things that you were thinking about. How are you seeing AI impacting clinicians when it comes to quality of patient care, time management, workflow management, maybe just more in the short term? I think a lot of us have these big, grand ideas of where AI can go, but are you seeing some real immediate areas where you're excited about, or maybe even you're already seeing impact?
Yeah, I mean, it can't come soon enough. I'm a huge proponent of AI for clinician efficiency and quality of life. And there has been some progress, and I'll share with you what's happening at Hopkins. I'll just start off by sharing with you that there was a recent publication in the Journal of General Internal Medicine that ranked all the subspecialties in terms of time spent in the electronic health record. Endocrinology is number 2. We spend upwards of 8 hours per day in the EHR. If I have a clinic that starts at 8 a.m. and ends at 5 p.m., with 16 patients scheduled, I'm probably up at 6:30 pre-charting, and I'm probably wrapping up documentation at 10 or 11.
Oh boy.
So there's at least 8 hours in the day that's just in the EMR. Diabetes is such a data-heavy specialty, so we're getting inundated with these patient advice requests. I ate ice cream, my sugar's 300, and it's just not tenable for us to continue to be able to see patients face to face and respond to these things. So there's a couple exciting areas where I think AI can help us. The one is AI's role in sort of summarizing the patient record, this pre-charting, before the clinician goes in the room. So if I have a patient with newly diagnosed, or if I have a patient, say, coming in who's been in our health system for maybe 20 years and has diabetes and multiple complications, it may actually take me 30 minutes to go through all of the records to figure out the details of their treatment history, et cetera. So, having an AI tool that can quickly process all that information and give you a one-liner, 52-year-old man with type 2 diabetes, diagnosed at age 45, treated with blah, 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 didn't tolerate this, currently at this level of control. That's an absolute game changer. It allows us to just like walk in the room and start in the present moment, so we can figure out what the next best step is.
Yep.
So automated chart review is functionality that is coming, I think, in Epic. The other is in clinic documentation and transcribing. So Hopkins recently, I think, we'll be implementing soon something called a bridge, which is, you've got your audio recording and it's hearing the encounter, and so summarizing the key elements of the HPI and the meds and the assessment and plan, and you can get those in your notes. And that's taking me away from the keyboard. I can look at my patient, I can connect to my patient, I can worry less about being a transcriptionist. And so that is super exciting. And that's, I think, going to be widespread very soon. So I see that the first widespread use of AI for clinical efficiency. The other area, I think, is in responding to patient messages. There is this triage process now where messages can be flagged as of a clinical nature or of an administrative request, like I need to reschedule my appointment, or I didn't get my lab orders or whatever, versus my glucose is 42 and I need help. And then I think further down the line, but what I think would be incredibly helpful in diabetes is clinical decision support. That is summarizing the entire situation and coming up with treatment recommendations based on practice guidelines. So where are the gaps in treatment? What would be the next best medication for this individual per practice guidelines, or even looking at other similar patients in the health and saying, like, someone just like you who went from these 2 drugs to this third one was more likely to be at goal in 3 months. And I think that that functionality does require a lot of rigorous evaluation, and will be harder to implement just because of FDA regulation of software and medical device, but could really help with clinical inertia in diabetes.
Yes,
Yep.
it's such a huge problem. I hear about that constantly from CDEs that I interview, and then patients that reach out to me who it's like their A1C has been over 8 for years, and they've never really, nothing's been offered to them to change anything, right?
Exactly. And there are some examples of these technologies that already exist. Like DreamMed has this, algorithm for treatment intensification based on the person. But there, in terms of adoption, there are cost barriers and workflow integration issues that need to be worked through. But very exciting potential application in that space of decision support.
Mm-hmm.
One of the things that is interesting to see is what seems like faster adoption of this technology versus maybe other technologies that have come out in the past, right? Just like even the movement to cloud, right? My friends that work at AWS and Azure, they're still trying to get healthcare organizations to move over. This feels like it's moving faster, and just even some of the things that you're talking about that you're adopting and Hopkins is adopting, it feels like we're moving faster here. And I would love to understand, do you feel like that's reality based on what you've seen of other technology adoption over the past, maybe decade or more? And what might be driving that if it is moving faster? Is that an internal thing, kind of a ecosystem thing, mixture of the two? What do you think?
I definitely agree that this technology, sort of large language model, text summary, is moving faster than other types of technologies. I think there's probably 2 things. One is that Epic, our EMR vendor, is taking the lead on this centrally, right? So it's not our health system that is having these negotiations with all of these products, but like Epic is thinking, well, this is amazing technology, right? Like it can mimic human speech. It's pretty darn close to accurate most of the time, and as a summary tool would be likely very effective. We need to reduce clinician burden in the EMR. They know that this is a big problem. There's a lot of burnout, and this is important to them. So I think it's moving fast because it's impressive technology, and it can make a huge impact immediately in many areas. Um, so whenever something happens, as part of the foundation system for the EMR, it's much easier for local health systems to adopt that. And I think the EMR vendors, I mean, there's going to be competition in this space, like who can offer the most AI functionality for the most types of tasks to, improve clinician well-being and patient care.
Yeah. I mean, Cerner just last week announced a complete revamp. I mean, Cerner Oracle, complete revamp of their platform, which is, as they say, I mean, they're claiming it's bottom up AI for this exact thing. So it sounds like there's some good competition happening for this particular aspect of taking care of clinicians and making sure it's a, to the extent possible, more delightful experience
Yeah.
within the EHR.
Mhm. Yeah, I mean, I do think, yeah, I think that the competition is important, and I think there's been enough now published about the impact of the EMR and the burden and burnout that something has to change, and we can't, especially with the prevalence of diabetes, like this is gonna, and the shortage of endocrinologists, it's just not, it's not possible. There are not enough
Yeah,
physicians to work.
yeah.
Um,
I think the ratio is in the States, isn't it like one endocrinologist for every 15,000, some
that
wild number of type 1, type 2 diabetics, right?
can't remember the fact of the shortage, but I think it's well over. I think it's 1,000 to 2,000 endocrinology shortage. If I left, but don't quote me on that. There's a huge shortage.
I mean, primary care physicians have to pick up a lot of the people that can't
Yeah,
get to an endo, right?
exactly.
Yeah.
Mm-hmm.
When you think about other teams trying to adopt some of these tools at other hospitals and health systems,
Mm-hmm.
any guidance that you might think about giving to them in terms of how best to align the organization, their team, in terms of trying to adopt these things? Because this is not just you want to bring in this tool, I would imagine,
Yeah.
and you get to use it on day one, right? There are other teams, other individuals, other departments you need to get alignment around. So, any guidance? I know we're early in the game here in terms of how to start driving these conversations with your organization and maybe help them accelerate their
Mm-hmm.
organization's use of AI.
Yeah, it's a good question. I think, well, to be honest with you, like currently at Hopkins, they're pilot testing products for all of these things, and so they're asking clinicians constantly to be the first to try out this tool for feed, and they're pilot testing the in basket management, categorization. So I think they're on it. I think what organizations can do, I mean, if a clinician has seen sort of some functionality, maybe they went to a talk and they saw that one health system was doing something, and it looks like it could be value added to them, is bringing that up to the CMIO of the organization and making an argument for its value. And like at Hopkins, we have committees that do this type of stuff, so they sort of there's like an appraisal process. But usually this results in, I mean, there's some sort of pilot phase where it's tested and feedback is given before it's widely adopted. And considering how fast this space is moving, I think that would be an important thing for anyone to do before committing
Yeah.
to this product.
Do you see anything different about the way that Hopkins is doing their pilot testing? Maybe it's just taking on more pilots, doing them faster. Is there any learnings there for maybe organizations that might not be doing that many pilots? Like, is there something unique that you all have found there and maybe some success learnings there?
Yeah, I mean the process. I would just say that I'm not at the I'm not at the table in sending out the communications to clinicians, but I've been on the receiving end of this, and I think emails just go out saying we're looking for clinicians who do X number of clinics per week and see have high volume patient care to give us feedback in this area, and if you're interested, let us know. And there's no shortage of clinicians who are interested because we it can't come soon enough. So
Yeah.
I I think I think there's enough need for this technology that it's just a matter of requesting pilot users, and I don't think that would be a hard thing for any health system to do.
Yeah, that's fair. Last question on this point. Are there any barriers that you foresee short term, long term in terms of implementing this technology? And it could be across some of the short term things that we've talked about, or even some maybe decision support, which is much more complex. Any barriers that you're seeing within healthcare organizations here?
Yeah, I mean there may be some. So like the abridge, for example, yeah, you got to get consent from the patient to record the encounter, and you are going to get patients that are going to say, "No way, you're not recording my conversation." You may actually even have some clinicians who would say, "I don't really feel comfortable having this entire encounter recorded."
Yeah,
Is the medical legal liability of that, and that I think that does need to be communicated very clearly. Is this discoverable information, or is only the transcribed final thing that you put in your note part of the record, right?
yeah,
Or that's just one example. And then errors, right? So when the AI technology is wrong, maybe it summarizes incorrectly, but you acted on that information and you didn't verify something and it caused harm, that like who is liable? Um, or even these classification of messages. So there will be times when it's wrong. I mean, as humans are, and understanding the repercussions of that will be important. Um, I think in terms of adoption, the most important thing though is integration within our existing workflows. So like during the pilot phase at Hopkins of one of these products, it was not yet integrated into Epic, and so the feedback, while useful in terms of like what the technology is not really reflective of, well, how will it actually work with the patient in the EMR. You have to go to an outside website and you have to cut and paste and put your stuff in your note, and that's an extra step. So that may influence your satisfaction with the product. So it's kind of the pilot test something if it's not in production in your EMR environment, but I think it's the best we can do. Um,
yeah. That brings up another question that um, I just thought of around this idea of it needing to be, these new technologies need to be operating within the EMR
yeah,
environment. And I think we've had a generation where there was a lot of products where it was a separate window that was um, outside of that environment that, and I think you just alluded to it, it's just not as productive and it's hard to really integrate it in.
yeah.
I guess more a guidance for new technology companies. How important is this, and is it becoming uh, the P0 requirement in order to work with healthcare organizations that it has to be in the EHR? And are there any exceptions to that?
It is probably the single most important thing, the interoperability uh, piece. And I'll give you some examples in the diabetes space. So continuous glucose monitor data, accessing that data for a patient's clinical visit right now. I'll
Yeah,
just tell you the steps that we have to do. Patient comes to the clinic, we got to figure out if they're using the mobile app or their reader. If they're using the reader, we have to connect it to the computer, upload the data, get a PDF, put it in the media tab. That's a lengthy process. If they're using the mobile app, they need to remember their login. They've got to be connected to our clinic portal. We've got to log into that portal, either transcribe the data or take a screenshot, put it in our note, or put it in the media tab. And even though some of the companies have been working on some workflows that will allow you to pull in the data, there have been some issues with that. So the match hasn't been good. I was thrilled at the diabetes technology meeting that Dexcom announced my integration. So you will share directly from your Dexcom device to MyChart. The data will be in the EMR. It could not be easier to access that information, and that we've got to make it easier for diabetes care because of the, you know, the vast amount of information we actually have to collect before we can make any decisions. So I think this is something that all insulin pump vendors need to do, right? So all of the insulin pump settings, all of the insulin pump delivery history just needs to push to my chart and just be right there when I open up the chart. So we're not wasting, 25 of the 20 minutes I have allocated for the patient just trying to get their data. It is an incredible amount of work.
Yeah, and even I remember the announcement that Dexcom made recently, and even then, it's a weekly summary, right,
Right.
of the data, if I remember correctly. So it's not everything. It's still just these snapshots, but that's a big leap in this whole world.
Just the way that the data are coming in outside of sort of Clarity, like it's not a, I don't have to log into Clarity, find the patient, put the order, because for someone who doesn't do this, we inevitably, you'll have a patient who doesn't remember their password to their Dexcom app, doesn't remember the password to the Clarity. You're spending 15 minutes as a physician dealing with password management, right?
Oh no.
For your Apple ID, oh, let's go here.
Yeah,
Let's like, and it's the whole visit time is taken up doing this type of stuff, and you know there's got to be a better way, and there is a better way, and it's coming. And I do so. My suggestion would be any company trying to create technology in healthcare that is pulling data from some source that a clinician is using for clinical decisions should try to get that information in the EMR.
yep, couldn't agree more.
Yeah.
All right. So, how could AI help in the growing obesity epidemic and diabetes epidemic? How are you hoping to use AI to help with diabetes prevention in those with pre-diabetes?
Yeah, so this is a really exciting area that I've been actively involved in with research. We're actually next month wrapping up a 12-month randomized controlled trial of 368 adults with prediabetes who receive AI-based diabetes prevention program, fully automated AI, an app and a digital scale. It's made by a company,
Wow.
Speech,
Okay.
versus the standard of care, which is a human coach-based diabetes prevention program. So this is going to be the first studies really in all of medicine to compare head-to-head the standard human-based intervention to AI technology. Can AI compete with a human coach in encouraging patients to make meaningful lifestyle changes?
Wow.
Really thrilled to see the results of that. But I will say that this space is exploding with apps. So some examples are, Lark, which is an AI-based chatbot that gives you, it's like a personal coach 24/7. January AI is another product that leverages continuous glucose monitor data, wearable device data, and AI to give you personalized insights into food choices, physical activity. How does the specific food or stress or whatever factor affect your glucose? And there are other examples like this, Levels and Signos or some other products. And these technologies are catering not just to people with prediabetes, just to this. We have healthy people asking for this information because they want to know very early on
Yep.
what foods are work best for them. And actually, one of the things I took from the diabetes technology meeting was there was a session on CGM and AI, and they showed how the same exact food given to two different people can affect them
Hmm.
so differently, like a banana and a cookie.
Wildly different. Yeah.
So it's not enough. The one size fits all recommendations of 5% weight loss, 150 minutes of physical activity, and low fat, low carb diet. Just it's not enough guidance for people.
Mhm.
I think the hyper personalization that AI offers with device integration has enormous potential. I will say that although these products are exploding, very few have been really rigorously tested against the standard of care. We don't have a lot of data on engagement and outcomes for
Yeah.
them, but we have every reason to believe that they would work. Because if you're looking at your glucose, that's immediate feedback that just can't be offered from the standard coaching.
Do you think some of that, the efficacy of an AI DPP,
Mhm.
would depend also on just the person's personality if they really need that human interaction versus,
It's a great
you know?
question. It's actually something we're very interested in, and in the study, we ask patients. We do a baseline questionnaire about the person's use of technology and social interactions and need for social support, and at the end whether they would have preferred getting the other intervention if they were randomized to digital. So we're going to explore that, but I do think that there will be a need for tools to say, is AI right for you given your personality, or is a human coach better for whatever reason, the emotional or social support, or even the accountability? Some people may not find an app something.
Yeah.
They may feel like you have to log in and see somebody, see my coach. I'm more accountable to that person, and they're going to be harder for me not to make a difference than it is to.
Yeah, on both sides of, it's the empathy isn't going to feel real from an app,
Yeah,
right? And the like, oh, I don't want to disappoint the coach. It's
right.
like, well, it's just an app, right?
Yeah.
So I don't feel judged.
Yeah. But I think that that will be an area of research, right, in the coming years, because we first need to prove that it's effective, that it's
Yeah.
as effective as standard, and then we need to have tools to kind of decide who's best for one versus the other
Yeah,
approach.
it would be great to have options.
Yeah.
Are you more enthusiastic about this generation of diabetes management, self-management tools than maybe the first generation? The Livongos, the Larks type of companies, which have come under a lot of scrutiny as of late, with several reports that have come out of the costs are really high and the outcomes are very low. And they've obviously all been fighting those reports, but
Yeah.
why is this next generation of tools different? Is it that it's being driven by AI, which can be more personalized? Like what's different, I guess, this decade versus last decade's set of
Yeah.
tools here?
I think it's the sophistication of the AI. I mean, we're talking about multimodal AI. So you've got a wearable device. You either have an Apple Watch or Fitbit. You've got a continuous glucose monitor. So we've got heart rate, we've got sleep, we've got blood glucose. We have photo-based meal detection, so we can track nutrition a little bit faster, and so the algorithm is likely to be more accurate. However, like I said before, these are very expensive. I actually have explored them myself, and I mean, if this is not paid for by insurance, then this is too costly for a large chunk of the
Yeah.
population. So we don't know. We need to know the cost effectiveness is going to require some rigorous evaluation on outcomes, and maybe it sounds sexy. It's like a little bit more hyper personalized, but the outcomes at the end of the day are not much more than the traditional approach. In which case, the cost will need to come down to for some people, it might just be an engagement tactic, right? I am likely to stick with this because it's giving me the feedback that's tailored to me, and it makes me more likely to continue using it than the generic recommendations, right? And so we know that engagement is important. So that might be enough to support use of these. But again, I think that cost effectiveness ratio is going to depend on, outcomes, which
Yep.
are lacking right now.
And maybe we can end on this question, but so many of these solutions that you mentioned, Levels, Signos, et cetera, they're
Yeah,
direct to consumer. But it sounds like the study that you all are doing is bringing those types of experiences into the clinical setting and is
right.
actually being driven alongside the clinician. So
Right.
do you foresee these as playing a potentially big role or being a big tool for clinicians in this area? And is that possibly going to drive its success versus some of the direct to consumer type models that are happening right now?
Yeah, absolutely. I mean, I think if we can demonstrate, for example, that the Switch app is as effective as the standard of care, and we've quantified the costs, then this could emerge as an alternative that would be covered by Medicare or insurers. And the clinician could have a conversation with the patient and offer this one versus the other, and it would be picked up by the payer. Um, and that financial model would mean that more people would get the technology than the direct to consumer one that is really limited to more affluent people. So I think it would need to be equivalent to the standard, and it would need to have this. I don't know if the payment model would be identical, but there would need to be reimbursement.
Yeah, yeah. All right. Ginger, any last thoughts?
Thank you for making time for this, considering how many hours in a day you need just to manage all of the reports. It's unbelievable how much work goes into endocrinology patient care outside of spending time with the patients. It's really, I hope solutions come to help with this soon.
It's much less time in the EMR because some of this stuff is in place.
Yeah.
Yeah.
Initial
Well, thank you
reaction.
so much again for coming on. This was amazing. Great conversation. Kind of all over the place in terms of where we were finding opportunities and some of the areas that you're really excited about. Obviously, AI, which we are too. So thank you so much again.
Oh, my pleasure. Thank you for having me.